Hello everyone. Myself, Dr. Vinod Kaushik, on the behalf of IIP India Digital Team, welcomes today IIP Women's Cell Andhra Pradesh State Branch. Today the topic of webinar is Rehabilitative Ultrasonography Imaging in the Indian Scenario. Really shows my gratitude towards Dr. Sanjeev K. Jha, IIP President, and Dr. Ruchi Vaishnavi, IIP Women's Cell National Head, for providing us this wonderful platform for sharing the knowledge. And today, the moderator of our webinar is Dr. Surbi Bhaduria. Ma'am is IIP Women's Cell Andhra Pradesh District Coordinator. Ma'am is having Master in the Cardiology and ma'am has been awarded India's first female physiotherapist who is continuously working since 2016 with WCPT Abstract Reviews Committee and reviewed more than 800 abstracts till now. Ma'am is member of Society Onco Physiotherapy of Tata Memorial Hospital. I just welcome all the delegates and just now hand over to Dr. Surbi Baduria. Please continue with the webinar.
Good evening, my senior, juniors, and my colleagues. First of all, I am thankful to Dr. Vinod sir to give such a wonderful and detailed introduction of mine. Thank you so much, Vinod sir. Hopefully, you all are doing well today. It is a very pleasure to meet myself, Dr. Surbi Bhadoria, District Coordinator, IAP Women's Cell, my co-organizer, Dr. Fatima Salma, sub-coordinator, and Dr. Monica, another sub-coordinator, would like to thank you for making our time for our amazing and new sprouted webinar topic today. It is great moment for us to have our renowned speaker. I believe today is going to be a good eve for all of us because we are all around the world impatiently waiting for this webinar in order to enrich our insight and knowledge regarding this thing. Before this webinar begins, please allow me to briefly introduce our adorable speaker, which is a fame of our webinar. I would like to introduce Dr. Summaiya Sheikh ma'am. She is an accomplished pediatric physiotherapist. She has completed her bachelor's from Sancheti Institute College of Physiotherapy, Pune, and master's in pediatric from Dr. D.Y. Patil College of Physiotherapy, Pune. She is currently working as an assistant professor in D.Y. Patil School of Physiotherapy, Navi Mumbai, and is also pursuing her PhD in rehabilitative ultrasonography imaging. Not to mention, she has several publications in journals of repute. She won third prize in poster competition at KLE Belgaum. She contributed to campus activities to promote positive university image. She stood first in master's program pediatrics. She mentored students and communicated internship and employment opportunities. She performed research to serve as basic of academic writing for publications. I would like to invite Dr. Summaiya Sheikh ma'am. Over to you, ma'am.
Thank you, Dr. Surabhi, Dr. Vinod, and Dr. Priyalini for such a wonderful introduction. And without further ado, I would like to start the webinar. The topic of today's webinar is rehabilitative ultrasonography imaging. So R stands for rehabilitative, US is ultrasonography and imaging, and what is the context of RUSI, the mnemonic in Indian scenario. So before we move to ultrasonography imaging, I'm sure all of us, I've been told actually that there are, my audience is a mixture of students, professionals, and academicians. So just to bridge the gap, I'm going to go a bit basic. We all know what is the abdominal drawing maneuver, but I have few questions regarding this. Okay, so before I move to the core topic, you can see how the transversus abdominis here is being activated when we do the drawing maneuver. And if you take a cross-sectional view, the outer one is the external, internal, and transversus abdominis. But when we are checking, when I want to rehabilitate this muscle, we all know the importance of this muscle for sure. And when I want to rehabilitate this muscle, I have a question that how do we measure the strength of this muscle? And from where do we move? What is the baseline? So the subjective confirmation is definitely via palpation, up and in when you ask the patient to do, and inferomedially to the ASIS. You palpate with the two fingers and the tendon, this bulge, you feel it on your hands. But my question is, how sure are we that only transversus abdominis is being targeted or activated specifically? So we know that this is the pressure biofeedback unit wherein objectivity is introduced. This is altogether a different discussion, prone versus supine. So I'm just going to stick to the topic. If I get time, I will discuss on this. So we, whenever you buy a pressure biofeedback unit, even in the booklet, you see that it is to be measured in supine position. So the patient is instructed to insert pressure on this cuff, and you have a dial here where the pressure, the amount of pressure in mm of Hg is deflected. In supine, it is supposed to be 40 mm of Hg and plus minus 5. But it is, so there are two things what the pressure biofeedback unit is going to tell me. It is going to tell me whether a patient can activate the transversus abdominis or cannot. So if my patient cannot activate the transversus abdominis, or if I'm not able to come to that pressure limit, which is set as 40 mm of Hg, it is, I conclude that my transversus is weak. Okay. But if I am able to maintain the pressure of 40 mm of Hg plus minus 5, it does not mean that I am activating the transversus specifically. What it means is it is giving me an indirect combined measure of transversus, internal, external, and rectus abdominis. So this is a false positive result which I'm getting. I'm not saying in all, but in most of them. So I have a proof using imaging, which I'm going to show you. Okay. Again, I will summarize that the ability to maintain the pressure of 40 for transversus abdominis muscle does not mean a strong transversus. Okay. With this, I will take you forward for the role of USG. How does rehabilitative ultrasonography imaging come into picture? Okay, what kind of objectivity does it bring? So the contents of today's lecture is, first of all, what is RUSI? How did RUSI foray into the physical therapy practice all over the world? What are the pros and cons for using RUSI for us physiotherapists? How are physiotherapists using it around the world? And finally, the facilitators and barriers in the Indian context. Now, this is the muscle where, if you can see the biceps muscle, whenever there is contraction, the increase in the cross-sectional thickness happens on contraction, which is called as the pistoning effect. So if this is a piston, and if I'm filling in air, the cross-sectional thickness is definitely going to increase. So whenever there is contraction, there is increase. It is directly proportional to the increase in cross-sectional thickness. This is what I'm going to view in ultrasonography. So this is, there are two images in front of you. One is on the left-hand side is the relaxation, where the muscles are relaxed, and in the first slide where the cross-sectional view I had shown you of the three muscles are being visualized here on ultrasonography. And on contraction or during the abdominal drawing maneuver, not post-contraction, it is during the abdominal drawing maneuver, what is the status? Now we will compare these two slides, on the left and on the right. So if you can see, I have demarcated here, this is the external oblique, internal oblique, and transversus abdominis. And on relaxation, these are the thicknesses over here, 1, 2, 3. Okay, so if you compare the thicknesses of 1 and 2, they are same. Internal oblique and external oblique aren't changing. The thickness is not changing, but which thickness is changing? Of the transversus abdominis. That is from 0.24, it is going to 0.37 centimeters. The difference is of 0.13 centimeter. If you convert it into millimeter, just for your understanding, it will be 1.3 millimeter. So this means RIA over here, the consent has been taken from the names which I'm using. RIA is able to contract transversus abdominis muscle specifically during the abdominal draw-in maneuver. So my hypothesis was, now I have another picture. So my hypothesis was, I had two individuals, Ria and Karthik. Okay, so why did I include these both? Because on the pressure biofeedback unit, they both showed me that they have the ability to maintain at 40 mm of Hg, the activation of transversus abdominis. But when I saw on USG, this is what I see. So RIA activated well. RIA specifically, preferentially activated the transversus abdominis muscle. But when I saw what Karthik did here, Karthik's internal, I mean, I don't have to even have to look at the values, the left and the middle one, if you see, it is obvious that he is activating internal oblique. And just to mention, these both are physiotherapy interns. So they know. Okay, I'm just giving you an information. They know what is the importance of transverses. They know how to activate, and obviously a previous training was also given by me. Okay, but when I saw, and I gave him one more chance to do, again it is the internal oblique. So this is what I want to say. So if you see the difference of internal oblique 1.09 to 1.46, 0.40 centimeters, 4 mm difference of internal oblique and transverse is also changing. I agree. Okay, this means that the pressure biofeedback unit is giving me a false positive result in some. I cannot say that transversus only is activated. Okay, it is the global muscles also which are responsible for putting a pressure on the cuff, which is deflected otherwise. So coming to RUSI, it is a procedure used by physical therapists to evaluate the morphology, the anatomy related to soft tissues and muscles, and provide biofeedback. So simply what you can say is, it is a potential tool and should be used as a stethoscope. So, you know, we use as a stethoscope to see what is the picture inside your lungs. These are the breath sounds and they are classified accordingly and all that. So this USG should be viewed as a stethoscope to view the muscles. What is happening in the muscles when you are training them, when you are dealing with them, when you're playing with them, what is happening. And the best quality of ultrasonography is that you can view it happening real time. It is dynamic. It is happening in front of you. So you can also see, as well as the patient or your client is equally involved. I mean, if you take the example of EMG, so if I'm skilled in EMG, you know, I can I can interpret EMG, but the client is nowhere involved in EMG. It is so difficult to interpret the visual graphs and sounds. So just a brief history of how RUSI came into picture. That is, after, you know, ships, they would use this sonar. For example, the Titanic in the last century, you know, they would use sonar where they would send sound waves at a particular frequency to assess the depth of the seafloor. So they would understand that, okay, there is a big rock underneath or at this level. So they would calculate the speed, distance and time taken to travel for the sound waves. Then it forayed into medical ultrasound. Then they started diagnosing brain tumors and everything. And finally, it came in the 2000s. Because of advanced technology, it is being used extensively in the field of musculoskeletal imaging. So as I have already told you, what are the pros of using USG over other modalities like MRI, CT, and EMG? EMG definitely, when you insert the needle, the risk of infection is the highest. The patient is absolutely not involved in that. You need skill definitely for everything. CT and MRI, on the other hand, they are expensive. There is an amount of radiation which you are exposing to the patient. X-rays I'm not talking about. I mean, we know that the X-rays are radiation, and this is at least better cost effective than the other imaging technologies. And all are operator dependent. You need expertise, you need skill of the operator. Okay, so the risk of infection is none. So in short, USG or ultrasonography imaging is dynamic, it is real time, it is non-invasive, it is safe. That is why it is used in pregnancy, because it is safe. So the cons Pros we know now, but what are the cons, disadvantages for using? I would not say disadvantages because it is variable. It depends on person to person. But if you talk about the practical application, it is difficult. Taking the patient to the ultrasonography room and everything, collaborating with them, it is difficult. But I think if you have decided that if you want to use this objective measure, then nothing can stop you. So the practical application is very variable. Cost might still be an issue in the Indian context, I agree. Collaborations again might not be an issue. It is variable. It depends on person to person and institute to institute. The one more thing is that the ownership will never be with the physiotherapist and a non-radiologist. Now I want to tell you, whenever ultrasonography comes into picture in India, there are two groups. There is a group of radiologists and a group of non-radiologists. So a non-radiologist means someone who's completed his MD in radiology. He's a radiologist. Non-radiologist means that even an orthopedic surgeon who is MD in ortho is a non-radiologist, anesthesiologist, intensivist, they are physiotherapist. Everyone comes in the non-radiologist group. So according to the Indian jurisdiction, non-radiologist cannot even touch the ultrasonography probe. They cannot. Only a radiologist can. Okay, so the ownership, the records, everything has to be with a radiologist and the radiology department. So the dependency factor is the highest, because if you really want to carry out research using this objective tool, you are entirely dependent on someone's skill, expertise, time, mood, emotions, and whatnot. And you're on different departments, different fields. So these factors are there. That is why I didn't call them disadvantages. I'm saying that they are cons, maybe a bit, they're variable. So therefore, basic training is a prerequisite. Basic training, and before that, a basic knowledge. So I want to actually take this point, not just in ultrasonography, in imaging, be it reading x-rays, be it reading CTs, MRI, or whatever it is, ultrasonography, this should be included in the curriculum, physiotherapy curriculum. At least a knowledge of how to interpret or how to read imaging, because this is the future of research, which the world outside is already using it. And these are certain other prerequisites for imaging. I mean, how to use ultrasonography imaging and why to use, because you need to know, for example, I mean, in any imaging technique, you need to know which plane you want to view in, why you want to view in, the type of probe, the frequency of probe, the mode, B mode, M mode, where do you have to put the location? Because if you saw in the previous images, the probe was only at one position. Now that position was in the mid clavicular line and 10 centimeters apart from the away lateral to the umbilicus. But why this position? Why not some other position? So there are always these questions. And why are you calculating for measuring thickness or certain activation ratios or whatever they are? So I have few examples here to summarize till now whatever I have said. The applications of ultrasonography imaging are divided into two. Rehabilitative ultrasonography imaging, if you use it for rehabilitation, it is RUSI. If you use it for diagnosis, it is diagnostic. So these examples I want to give. There are 4 articles which I've taken, okay, and these are by Indian authors. So if you see the first one, the efficacy of Pilates, the protocol, a 6-week, I think, protocol was given, and they have assessed what is the thickness, change in thickness of the abdominal muscles using ultrasonography imaging. Role of Mool Bandha while practicing Bastrika and Kapalbhati, and they have seen it, how is it they have correlated it with bladder dysfunction. So they have measured retroversion angle of the uterus and certain IDs and PDs, which is the posterior displacement and inferior displacement of the uterus using ultrasonography imaging. How much is the displacement in mm? Again, movement with mobilization in shoulder impingement syndrome. So if you can see this image here, they have measured the acromiohumeral distance and the supraspinatus tendon thickness, SST, using ultrasonography. Means, what does it mean? That does movement with mobilization of the AC joint, does it have an effect? I mean, pain and function are definitely improving, but what is the anatomical difference? Does it really have an effect, or it is just placebo, something else? I mean, so this is the objective answer. The fourth one, Russian currents and strengthening was given for the quadriceps muscle. So these are the 4 muscles. intermedius, medius lateralis, rectus femoris, and the thickness was seen over a period of time. So these are diagnostic and rehabilitative studies. And I would just like to mention that all these authors, Dr. Shivani Chaudhary, Dr. Unnati Pandit, Dr. Ajit Dabholkar, they have been my guides. And currently Dr. Tejaswi Dabholkar, she is my current guide for this in this field. I would like to thank them. Now, just because the outside world is using ultrasonography, so should we also start using that? Is it just a fashion? So what Hodges says in 2005 is no, it has a strong potential to contribute to rehabilitation because it has no side effects. This is the article which I've added here. Yes, the client and therapist both are involved equally, and it is so easy. I mean, a client, a patient who has no knowledge of anatomy and anything, and if you just show them the screen, you have to increase this thickness. It is so easy for the patient to understand. A great medium of visual biofeedback, superb medium of visual biofeedback. As discussed, increased feedback and patient satisfaction for better outcomes. Now coming to the Indian scenario, the PCP-NDT Act, Preconception Prenatal Diagnostic Technique Act in 1994, which was modified, I think, in 2003 or 2005. What it was made to curb female infanticide, and it regulated the use of ultrasonography only by radiologists and radiology setups. So as I said, non-radiologist physicians, orthopedicians, anesthesiologists, emergency medicines, intensivists, they are not allowed to use. And here, therefore, I've used this term, rehabilitation providers. We are rehabilitation providers. Rehabilitation providers includes physiotherapists, occupational therapists, speech therapists, all the providers who give rehab. So literature by these rehab providers, it is extensive outside India. But here, the body of work by Indian physiotherapists is almost negligible. Why? Because, I mean, it is obvious the jurisdiction and the laws and the rules which we have to abide by. But that does not, so if you cannot foray anywhere near it, does not mean that you cannot use it. And this was the main reason why I wanted to create awareness using this platform. So if you cannot directly use it, you use it indirectly. I mean, it is such a wonderful tool, such a wonderful equipment. You collaborate because collaboration is the key. You introduce training protocols, as I mentioned. It should start from the basic and the grassroots level. At least knowledge, because it is no harm, and we need to progress. Because these training protocols have been introduced in Canada, United States, and in India for the non-radiologist population. It has been already introduced. So encouraging out-of-box thinking is very, very important for these young minds. Extremely important, because they should know, I mean, we all should know that these techniques can be coupled with any sort of imaging to form a solid research background. Why not ultrasonography imaging? And I have a small message. This is an opinion from a radiologist, Dr. Sanjay Pasoria. He is MD in radiology department, MD in radiology from our department of DY Patil University. So I will just play the video, a short message.
Hello friends, I am Dr. Sanjay Pasoria, radiologist. I just want to say that ultrasound acts as an eye for a treating doctor, or in our case, physiotherapist. Hence, the anatomy of the patient can be studied like relaxation and activation of the muscle in real time and documented with confidence. So, we play an important role in the evaluation. Thank you.
I think this is self-explanatory.
Hello friends, I am Dr. Sanjay.
Yeah. So physiotherapists are one of the professions who are suitable for their background in anatomy, biomechanics, pathology. So for any professional, it is a long learning curve. If we start now, maybe 10, 15 years down the line, it will become common. Okay. And a take-home message finally is that, see, because it is an entirely different field. So foraying into some another field should be with an aim to bring out the best in both and not overpower each other. So it should be but to empower each other. So you should aim to bring the best in both. Collaborations which are there, I mean, which will happen eventually, not just with respect to radiology, but with any this field, they should be ethically practiced using MOUs and drafts, memorandum of understandings, etc. So I'm not saying that PBU is a bad tool. It is a good tool. So, but as a physical therapist, as a physiotherapist, it is my duty to know what are the pros and cons, advantages and disadvantages of each and every tool that I am using. So what you do is you seek the best quality of each and every tool. All the modalities are useful, and you create something new, innovate. So the bottom line is to create a practical, client-centered, maximizing objectivity over specificity. Uh, since we have a little bit of time, I had not introduced these technical aspects. Just to end it, there is a difference between abdominal hollowing and abdominal bracing exercises. So what I had discussed earlier, and that is the abdominal draw-in maneuver. It is a type of, it comes under abdominal hollowing exercises. So hollow means you create a hollow, and bracing is wherein you are specifically activating only the transversus abdominis. But in bracing, the external, internal oblique rectus abdominis embrace the transversus abdominis. So it is a deliberate action when you're performing abdominal bracing exercises. This is an important thing to note. Also, in the earlier slide, when I was saying that the pressure biofeedback unit, we have, I mean, even in Kistner says that you test it in supine position, you train it in supine position. Yes, why not? But recently a lot of research is being done that this same can be done in prone position. Because when Richardson, we have the Richardson's grading also, when Richardson said that check whether the patient is able to maintain 40 or not, plus minus 5 given for a certain amount of time. That is what we do. We just see 40 hai ya nahi hai. But he also said there are 3 important conditions for this. You have to also check whether the spine, the rib cage, and the pelvis, what is the position of these 3 things. Okay, because if there is an increased anterior pelvic tilt, if there is an increase in lordosis, and if the spine, the rib cage is getting elevated, pressure is of no use. The intra-abdominal pressure is not efficient and appropriate. So whatever you document will not work. So what did researchers do is they thought of, instead of supine, you take the patient in prone. So your rib cage is stabilized, your curve, how much will it increase, how much will the lordosis increase in prone, and the pelvis is stabilized. But the pressure is not 40. For prone it is 70. And one more thing is that 70 mm of Hg, and one more thing is that 40 is you go above 40 usually in supine, but in prone you have to go below 70 because you're taking the pressure off the cuff. So it is 6 to 10 mm of Hg. So finally I end my presentation, and I would like to thank the IIP Women's Cell Andhra Pradesh, National Head Dr. Ruchi Varshney, the South Zonal Head Dr. Ramya Senthil Kumar, the State Coordinator Dr. Priyalini Sarkar, Dr. Surbi Badoria for being an excellent district coordinator, Dr. S. Nagasai Monica, and Dr. Fatima Salma, both are district sub-coordinators. Thank you. And Dr. Vikas also. Thank you so much. I would like to end this slide by this quote, my presentation with this quote. And any questions or opinions are welcome. Thank you.
Thank you
Thank you
so
so
much,
much,
Dr.
Dr. Summaiya. And I guess we have a question from Tejashree Dabolkar. Surbi, can you please
Yes.
ask the question to Dr. Summaiya?
Yes, ma'am, definitely. Dr. Summaiya, here one question is there. Can focus point of care ultrasound be used for rehabilitation purpose?
Yes, very much, Dr. Tejashree. Focus is point of care of ultrasound. So point of care of ultrasound means bedside ultrasonography evaluation. I'll give you an example. Take an example of an orthopedic surgeon. Okay, a patient comes to the orthopedic surgeon after maybe 4 weeks or 6 weeks of having a fracture, and he will send the patient to get an X-ray done, and then you come back to me. I will see whether how much is the callus formation and etc. things. If there was an ultrasonography machine with the orthopedic surgeon, or a sonologist or radiologist using the ultrasonography machine, whatever is the condition, he would just place the ultrasonography machine over the supracondylar fracture if he had, and visualize how much is the callus, how much is the healing. So this it is so easy and so much convenient for the patient as well as the treating surgeon and doctor. It is similar with the physical therapist. So if a patient is coming for rehabilitation to you, this is the best method, and it is just a matter of minutes. Just a matter of minutes. So I'm not saying that I would also like to say that I'm not saying that the non-radiologist should be given the foray and portal to use ultrasonography. No, I'm not saying that. Within the jurisdiction, I think this practice should be encouraged more and more. Yeah, thank you.
I have one question, ma'am.
So,
Yeah. Can you have some published papers for prone position? That is a very good
yeah.
position we will find.
Yes, I have papers, and
Yeah.
if I will just email you, I also have a systematic review
Okay.
wherein all these papers which have been published before are analyzed, and a review is presented, and they are saying that the prone positioning, which is there, why is it also beneficial is because it maintains your intra-abdominal pressure. So there are many things actually in this which I did not say, because when you are in prone, obviously the ribcage, spine, pelvis are all taken in control. You increase the pressure. But why is this 70 and why not 40? Why is it 17 prone? Because the abdominal contents, they are putting the pressure on the muscles. There is so much weight of the abdominal contents also, which is deflecting on the cuff. So to take off that pressure, something that we can control is externally, and that is the pressure in the cuff. So you increase the pressure. And I will definitely send you the this review and articles. And one more thing is that muscles should be assessed against gravity.
And can you share? Please stop your screen sharing.
Yeah.
Yeah. So actually, we have so many questions.
Yeah.
To that. Yeah. Yes. Continue, ma'am.
Yeah. So I was saying just one last point, that muscles should be assessed against gravity. So for transverse abdominis against gravity, best is the prone positioning.
Okay. One more question from Tejashree, ma'am. Can ultrasound have community project applications?
It definitely has a lot of I mean, I don't know. I don't know whether it has community project applications or not, but I think the question is so valid because first of all, to reach out to the community, I mean the outside community, apart from the physiotherapist, we have to create awareness within the community. So I'm sure it has wonderful community project applications, wonderful, to bring out so much objectivity, as you all saw in the Indian literature also, how they have used because see, if they are calculating certain angles and thicknesses, nobody can question your work, original work. Nobody can question it. Is so much, it brings so much objectivity. But yes, it has a lot of community project applications, but I think their awareness within us physiotherapists, because today if I take a survey of how many people know amongst physiotherapists that ultrasonography can be used, I mean, we all know the answer. So that awareness has to be done within us first.
Can we have to take any permission from ultrasonographic association or with our physiotherapy association?
I
Regulation
think,
for that.
yeah, it's a very important question, because I would like to share my personal experience. As in the introduction also, you all mentioned that I am doing my PhD in this topic. and I've been guided by Dr. Tejashree Dabulkar only. The thing is, when we started with this, I also had these questions in my mind. So I went and spoke with the radiologist, and they gave me similar answers that obviously you will need a mediator, you will need us in between. Speaking to them, the Indian Radiological Association, or talking to them, will definitely be useful. But I don't think so. Permission is the correct word, because if two parties are collaborating, I mean, both the parties are working together in one thing. So where I don't think so. Permission comes into picture, because I am going to follow the Indian law, the law of my soil, which says that any non-radiologist, not just physiotherapist, orthopedic, intensivist, because intensivist can also use ultrasonography in ICUs. Suppose if there is an emergency case of pulmonary embolism, now instead of doing a Doppler and other things and calling the different people, I can just do POCUS, point of care ultrasonography. The intensivist can do, and the intensivist is also knows anatomy and everything. So what I'm saying is, permission is not the apt word. I feel it is, first of all, again, I will repeat the same thing. We should be aware of what we can do and collaborate. So collaboration in every field, like, we are using functional MRIs, but the cost is too much. So we can't take a large sample size for our studies. So let us use this. It is a cheaper thing. And wherever there are institutes, I feel we should collaborate. That is the best quality, because I can understand the practical difficulty is in a clinical setup, collaboration is not possible. I will have to go to the other clinic, and these are the practical difficulties which I'm facing. But I think wherever there are institutes, this should be encouraged. I hope I answered it.
Yes, if I may add to that, permission is not the right word, as you said, but we can use something called as mutual understanding about the concept is something that is needed to collaborate. So
Like
that
a memorandum of understanding, MOUs, a drafts,
Yeah, that is true.
agreement between two parties, definitely.
Yes, yes.
so that will work out here in the projects.
Any other question, ma'am? In the chat box? Check.
Yeah, we don't have any more questions, and the YouTube is also, we don't have any questions there. So it's a clear-cut session, I guess.
Thank you. Thank you.
But it's a very informative, ma'am. It's a new thing which every physio should know about this.
I've also shared my email ID and number. So if
Yeah.
in case there are any other doubts, you all can always contact me.
Definitely.
Thank you.
Yagini, ma'am, please speak a little bit about our webinar.
Yeah. First of all, good evening all. I'm Dr. Priyalini Sarkar, the state coordinator of IAPWC Andhra Pradesh. And I'm very glad that this session happened today. Thank you, Dr. Summaiya, because that's a very informative session that you have taken us through. It's short, it's crystal, it's clear. And that is the need of the hour also. Right now, there are a lot of things that are happening, lot of developments that are happening, throwing light on the subjects that are very important for right now. This is the best platform that IAP has given us to organize webinars, and I'm very glad that this subject we heard it today from you. Thank you so much. That's a wonderful session. And my IAPWC National Head, Dr. Ruchi Vaishnav, ma'am, thank you so much for always giving us the freedom to choose the subjects we want to do. And Ramya ma'am, thank you for all the support you give us. Coming to IAPWC Krishna district. So district coordinators, Dr. Surbi, and sub-coordinators Monica and Dr. Fatima, you did a fantastic job, because unlike every time, I just gave you the freedom to do whatever you want to do. From the subject, you selected the webinar topic, to the speaker, to organizing everything. I just logged in 5 minutes ago. But you did a fantastic job. For your very first webinar, the topic you choose, the speaker you choose, the session it's happening, the way it's happening, it's wonderful. Hearty congratulations to all of you. And please keep coming with more webinars, because physiotherapy is a very booming profession right now. We need to show a way to our juniors how important physiotherapy is right now in each and every field. And for that to happen, this is the wonderful platform we can use. And I'm really glad that you people came up with such a wonderful topic for your very first webinar. Hearty congratulations, everyone. And IAPWC AP will always be there to do these wonderful works with the support of IAPWC National Head and South Zonal Head support. So once again, congratulations to each and every one of you. It's a huge success. And let's look forward for more from you people. Thank you.
Thank you so much, ma'am, for a wonderful message given by you. I'm really grateful to you. So we are now coming up with our thank
Yeah,
you note.
and one more thing, I'm sorry, I have to thank the IAP technical team. Vinod sir, Uttara ma'am, Manika ma'am, and the entire technical team. Thank you so much because you are making the webinars possible. We know nothing, we are just relying on you, but you are making the best out of everything. Thank you so much, Vinod sir. Right now you're here. Thank you so much.
Hello, everyone. Thank you so much, ma'am. I am continuing with the thank you note. Hello, everyone. I am Dr. Surbi Bhadoria, District Coordinator, IAP APWC. On behalf of organizing team, we just want to take a minute to say thank you. I want to express my sincere gratitude to Dr. Summaiya Zareen Sheikh ma'am to enlighten us on motivation and skills for ultrasonography imaging. In the Indian scenario, her inspiration, lecture, and sharing her visionary approach will help to every one of us achieving great things in life. There were many aspects which were discussed today, which will definitely unite many unnoticed knots of science and knowledge. I would like to thank Dr. Sanjeev Jha sir, Honorable President of IAB India, for this valuable presence and inspiration. Without that, the conduct of webinar may not be successful. Next, I would like to mention about the true leadership and support of Dr. Ruchi Ashne ma'am, the national head of IAPWC team, to plan such a webinar on very important topics of everyone's life. I would also like to say thank you to participants because without you, the webinar may not be successful. I would like to mention a sincere thanks to our zonal head of IAP APWC, Dr. Ramya Senthil ma'am, to execute the plan successfully. I would also like to mention about the team spirit and proper execution of the webinar in a very short span of the time. Thanks to Priyalini Sarkar ma'am, State Coordinator of IAP APWC, for their restlessness effort to execute the plan effectively and to bring the webinars on the real ground. At last, I would like to mention a true passion towards work to the Krishna district team, Dr. Fatima and Dr. Monica, and to the members of organization and technical team of IAP India. Dr. Vinod sir, thank you so much. Without their support, this webinar would not be possible. Thank you so much, ma'am. Everyone here present, thank you so much for giving your a lot of time to listen. Thank you a lot. Dr. Vinod sir, this is for you.
Thanks a lot, everyone, for this wonderful, informative webinar. I just showed my gratitude towards everyone, and I just request everyone please subscribe IAP India YouTube channel and other social media channels like Twitter and Instagram and that LinkedIn and the Facebook page. Please with us. Thanks a lot, everyone. Thanks for the informative session. Thanks, IAP Women's Cell